Hi, good afternoon. I'm Saud sifri, endocrinologist from Al-Hada Armed Forces Hospital. Today it's an honor and pleasure for me to talk about one of those landmark trials which has changed the paradigm of diabetes management. And in this, it's a part of a program across type 2 diabetes, CME online. In this study, which is an empiric outcome study, I'm going to introduce what was the rationale for doing such a study, and then I would talk about the design for the study, and then the main cardiovascular outcome from the trial, as well as I'm going to talk about a part of it in which it was the renal outcome from the empiric outcome, and then I will summarize what we have found from this study. As you have seen here, this was the trial design for the study. It was a randomized, double-blind, placebo-controlled cardiovascular outcome trial in which it was going to examine the long-term effect of empagliflozin, one of those SGLT2 inhibitors, in addition or in top of the standard of care in patients with type 2 diabetes, in order to examine the cardiovascular safety in those patients. As you have seen now, the participating centers all over the world was 590 sites in more than 42 countries. And in this, if you would see the geographical distribution, it has involved all the continents, which gives more generalizations of the data whenever we are going to discuss. As you have seen, more than 11,000 patients, they have been screened, and out of those, around 7,000 patients, they had been randomized. Now, for randomization, it has been done in 3 arms. One of the arms was empagliflozin 25 milligram per day, where it was put on top of standard of care. Now, the second arm was again empagliflozin, but in a different dose, 10 milligram once daily on top of standard of care. And now for the third arm, it was standard of care plus placebo. And then they would follow for a certain period of time in order to get the required event to get the outcome result. And those were 591 events. And if you would see, or to be more specific, it is 691 events who had experienced an outcome event. And in those, you would see that around 2,500 patients, they had been randomized into each arm. Now, the main inclusion criteria of those patients, they have to be an adults, and again with type 2 diabetes, with a BMI less than 45 kilogram per square meters, and again their hemoglobin A1C has to be more than 7% and less than 10%, and then they have to have an established cardiovascular disease. So we are targeting populations whom they have got a cardiovascular disease, either as an established with a prior MI or coronary artery disease, stroke or unstable angina, or those who has got an exclusive or occlusive arterial vascular disease. Now, the exclusion criteria were those patients whom the class as SGLT2 inhibitors were excluded with the estimated GFR less than 30 ml per minute per 1.73 square meters in those patients. Now, the outcome we were looking for as a primary endpoint, those were major adverse cardiovascular events. And out of those, there were 3 points, and in that, it was cardiovascular death or non-fatal MI or non-fatal stroke. Now, even they have included a key secondary endpoints in which it was added to the first 3 hospitalization because of unstable angina. Now, they have got also other pre-specified secondary outcomes, and in those, they wanted to look into each individual outcome. And with those, either the cardiovascular death, non-fatal MI or non-fatal stroke, hospitalization because of heart failure, or all-cause mortality, death due to any cause. all these cardiovascular events and neurological events, they were adjudicated by an independent masked clinical event committee, which is one of the required for terms of safety in order to have the trial ongoing. Now, if you would look at the baseline characteristic of those patients in those three arms, either in the placebo on top of standard of care, plus in the other empagliflozin, either 10 milligram or 25 milligram, you would find that basically all the three arms, they were equally distributed. And with this, the average baseline age was around 63, and almost 3/4 of them, they were male, and A1C and average baseline was around 8%. And with this, if you would look at the duration of diabetes, you would find almost more than half of them, they have got long duration of diabetes, which is more than 10 years. Now, this is also an important issue also when you consider those kind of patients whom they have got a very high risk or an established cardiovascular disease plus longer duration of diabetes, the medications which they are using in order to control their glycemia. And if you would see that almost 3/4 of them are using metformin, while sulfonylurea is almost like 40% in each arm. Again, if you would see almost half of them, they were using insulin, and the mean daily dose was equal in the three groups, which was around 52 units. So it tells you that these patients, they were having a very longer duration of diabetes with established complications. Now, when we want to look at particular their cardiovascular disease status at the baseline, you would see that almost 99% of them, they have got a cardiovascular risk factor. Either they had a coronary artery disease or an MI or bypass graft or a history of stroke or heart failure, in which they were almost like 10% in each arm. Now, the other thing, when you look at those, you would find their average BMI was around 30, and again, their systolic and diastolic blood pressure was relatively well controlled, around 135/70. Again, if you would look at their parameters, they were relatively, LDL were relatively controlled with an average LDL of around 85 milligram per deciliter. And again, if you would look at their estimated GFR, we're talking almost about 1/4 of them whom they have got an estimated GFR, which is between 30 and 60 ml, which tells you that some of them, they have got an advanced chronic kidney disease. Now, other than this, it's important to see what kind of medication they are receiving for their cardiovascular disease. And in this, if you would see that, you will find 95% of them, they were receiving antihypertensive therapy. Most of it is really ACE inhibitors or ARB, and in this, they were around 80% of them. Now, again, an important other issues which you would look for is the lipid-lowering agents. And the good thing that almost 75% of them, they were receiving statins. And again, if you would look for antiplatelets and others, you would find those patients with an advanced disease, they have got almost 80% of them, they are receiving an aspirin. Again, now if you would see with those dispositions of those patients, the good thing that almost 99.3% of those patients, almost like 100%, they have got their vital status availability. And it means that they had been followed, and only those patients who had been lost for follow-up, they were around 1%. Now, again, the median exposure of those patients, they were almost 1.8 to almost 3.4 years, which tells you that it's a relatively, within a short period of time, we had reached the events which is required for the trial to be done. Now, with all these background, let's look and see. So our aim was to show that by using empagliflozin in each arm, that it does not have any worsening in terms of their cardiovascular event. And we want to see that it is non-inferior to placebo. Now, if you would see in this diagram, you would see those patients whom they were receiving placebo on top of standard of care, they were having an event rate of almost like 16% in those who had received placebo. Now let's see those patients who received either empagliflozin 10 milligram or 25 milligram, and let's see, those are with the red lines. If you would see that the separation of the curve has been seen almost by 3 months, and this has been a continuous diversion of the curve between the two arms in favor of empagliflozin, where there was a significant risk reduction by almost 14% for the whole 3 points major adverse cardiovascular events, which was cardiovascular death, non-fatal MI, or non-fatal stroke, in which the p-value was very significant. So it tells us from here that it was not only non-inferior to placebo, but again, it was superior to placebo. By using empagliflozin in those patients, you can reduce the 3 points major adverse cardiovascular events. Now, if you want to look into individual component of those major adverse cardiovascular events, as if you are seeing on the graph, this is the cardiovascular death, and again, we are seeing that almost they would get 9% of cardiovascular death by using placebo on top of cardiovascular, on top of standard of care, compared to those who would receive empagliflozin by almost 4%. So using an empagliflozin, whether 10 or 25 milligram, it's going to give a relative risk reduction by 38%, which was really very significant. Now, if you would to look into those 3 points or the 4 points, where you would add for it hospitalization for unstable angina, again, you would see that it was all of them on the left of the unity line, which tells you that it was all of them, each point, it was in favor of using empagliflozin in top of standard of care compared to placebo. Now, another important issue, which has been specified before, it was hospitalization for heart failure. And again, as if you have seen here on the line, that those who had received empagliflozin, they have got significant risk reduction of hospitalization due to heart failure by almost 35%, which was really very significant. Now, another one is the pre-specified secondary endpoint, which was all-cause mortality. And with this, if you would see those patients on the red line who had been using empagliflozin, whether 10 or 20 or 25 milligram, they have got significant risk reductions by almost 32% by using empagliflozin over placebo. Now, if we want to combine all of those, the all-cause mortality as well as cardiovascular death or even death due to non-cardiovascular cause, we are talking that all of them in the arm of empagliflozin, it was superior, and it was in favor of using empagliflozin in top of placebo. Now, other issue we want to look is the effectiveness data of those. And now, if you would see in those safety trials, we would try our best that both arms with active competitors compared to placebo, they should not have a very significant difference in terms of A1C or glycemic control or other parameters. But again, here, if you would see that the A1C difference at the end of the trial, it was like 0.4% of A1C. And again, if you would look at the weight compared to those who received placebo, they have got a reduction of weight of almost 2 to 3 kg by the end of the trial. Now, again, if you would look at the LDL or HDL, there was no significant difference between two arms, those who received placebo or either dose of empagliflozin. Now, another issue which we are very particular about it is the safety and tolerability of empagliflozin. And the good thing, if you would compare now the three arms, those who received placebo or empagliflozin 10 milligram or 25 milligram, you would find that there was no difference in terms of either one or more adverse events of the drug. Even if you would look into terms of those which is related to the drug, there was no difference in terms of their related adverse events to the drug. Now, even if you would look into one of those serious adverse events, there was no difference whether they would receive placebo or empagliflozin. Now we would go into more details in this. One of the issues which has been raised with the class is the diabetic or euglycemic diabetic ketoacidosis. And luckily here we would see in those three arms there was no difference whether using empagliflozin or placebo. One of the important things which has been noticed that in patients who had used empagliflozin, whether it is 10 or 25 milligram, there was an increased chances of having a genital infection. And again, if you would see those, the good thing if you would see in the two arms of empagliflozin, the 10 milligram and the 25 milligram, there was no difference in the chances or in the events of genital infection. So it was not dose dependent. Whether 10 or 25 milligram, they were the same. The good reassuring things that in case of volume depletion and bone fracture, there was no difference between placebo and empagliflozin. So it was reassuring for us. Now to summarize what we have mentioned now, this is what we have seen from the EMBARK outcome trial, that it has got 15% significant reduction in terms of major adverse cardiovascular events, in terms of cardiovascular death, as well as non-fatal MI or non-fatal stroke. In the individuals, more than 35% reduction in terms of their cardiovascular death, or 32% as all-cause mortality reduction by using empagliflozin. Again, the good thing that they have got 35% risk reduction of hospitalization due to heart failure. This was in patients who have got type 2 diabetes in top of their standard of care by using empagliflozin. Now, since the era of ACE inhibitors, where it became one of the standard of treating patients who has got diabetes and hypertension, simvastatin has been used for almost 5.4 years, in which you would need to treat 30 patients for more than 5 years in order to prevent one of the cardiovascular death. While in terms of ramipril, where you need to treat for 5 years in order to 56 patients in order to prevent one death. Now the good thing now, by using empagliflozin, you would need to treat for a shorter period of time, around 3 years, and by this you need to treat 39 patients in order to prevent one cardiovascular death. Now, since this has been a landmark trials which has really changed the paradigm of management of type 2 diabetes, now you would see that with all this, they wanted to look into the microvascular impact of using empagliflozin in those patients with type 2. Now with this, they wanted to look into the renal outcome. Does it have a difference in this? And with this, they wanted to look into the composite microvascular outcome in those patients. And with this, if you would see again, they have looked into the baseline estimated GFR of those patients. And here they have looked into between those who have got estimated GFR less than 60 or those who has got an estimated GFR more than 60. Again, their age average in the two groups, whether empagliflozin or placebo, they were the same, around 67. Again, most of them, they were male, and they had been from different ethnic backgrounds. And again, their average BMI was around 31% in the whole groups. Again, if you would see their average hemoglobin A1C, it was around 8, and this was the average in all of those. Now, based on the estimated GFR, again, these are their medications. Most of them are using sulfonylurea, as well as they were using some of them dual therapy, where they were compromising around 45% of them. Now, the microvascular analysis, again, if you would see here that for the composite microvascular outcome, all of them, it was in favor of empagliflozin, and with this, there was a reduction of almost 38% by using this, and the hazard ratio was around 0.62, which was really very significant in terms of this. Now we wanted to look into what was this coming from them. And when they looked, they found that it was mainly driven by the incidental or worsening of the nephropathy. And again, now when we wanted to look into the new onset or worsening of nephropathy, you would see in the red line that by using empagliflozin 10 or 25 milligram, again we have got almost 39% risk reduction by using empagliflozin in those patients on top of placebo. Now, when we want to look at the new onset of macroalbuminuria, again there was a 38% reduction in those who had been using empagliflozin compared to placebo. Now, when they looked into the doubling of the serum creatinine in patients who have got an estimated GFR which is less than 45, again there was significant reduction by almost 44% by using empagliflozin. Again, one of the important things, always we assess the first time for initiation of continuous renal replacement therapy in those patients, and again you would see that there was significant reduction by using empagliflozin by almost 55% reduction in that one. Now, definitely all these results, which has been really one of the things that we were not expecting in the beginning, it has really changed the guidelines. Always guidelines are not changed easily. They would need a very well recognized trials in which they would change their guidelines. But as if you have seen, American Diabetes Association in their latest edition, they have added empagliflozin in particular by name because of the empiric outcome trial that in those patients who have got high cardiovascular disease with type 2 diabetes, empagliflozin are advised to be used with those patients. Not only this, even the Canadian Diabetes Associations, they have added clearly that empagliflozin is recommended for those patients who have got an established cardiovascular disease with type 2. And with this, really, I would like to thank you. Thank you all for your listening. Thank you.